Hello again. It's nice to see so many of the same faces back after the break. I hope everyone is feeling recharged. The afternoon will continue to deliver some exciting content. All the content from today will be available to view on demand within 24 to 48 hours. So don't worry if you missed something earlier. So let's explore one of the many focal points of today's event, elective treatment. The elective care waiting lists on the NHS could reach between 7 and 12 million by 2025, raising concerns that nursing workforce numbers and bed capacity are not keeping up with rising demand. While the NHS provided a remarkable amount of elective treatment during the pandemic, the pressure of caring for large numbers of patients seriously ill with COVID has resulted in the longest waiting list for elective care since records began. This panel seeks to share best practices across the health sector and to investigate the best improvements in technology, technique, and recovery to get people in and out of hospitals faster. Our panelists for this discussion are Ellen Coughlan, Programme Manager, Analytical Capability at the Health Foundation. We're hoping we may be joined by Jonathon Holmes, Position Policy Advisor, Teams Policy for King's Fund. We haven't quite got him on yet, hence the slight delay of us starting this afternoon's session. We are working on it. And we've got David Ezra for you, Managing Director of Vantage Health. And don't forget, there's the Q&A feature to the right-hand side of your screens. It's built in so that you can have your voice included in the conversation. So if you've got a picture to begin with for Ellen or David, then do pop that question in and I shall do my best to get it to you. So welcome, Ellen. Welcome, David. A report that I was reading during the prep for all this said that 5.6 million people are waiting for treatment. As we said in the introduction, that's the highest number since records began. And that figure could rise in the coming months to 12 million, possibly 13 million. I'm just wondering, Ellen, if you can kick us off, what's the impact of big waiting lists, firstly on people?
Yeah, those are big numbers that you were just talking about, aren't they? I mean, from a human perspective, people living in pain and discomfort is absolutely something that we all want to avoid and want to address. You know, at best, waiting for treatment is frustrating and uncomfortable, but at worst, it really sees people's health deteriorate and, their outcomes worsen. And it can impact people's financial security as well, because if you think, people can't go to work, perhaps. And Healthwatch England recently did a poll that found that almost half of adults who were experiencing a delay in their treatment said it impacted their ability to work. So from that very human perspective, it's a huge issue. But also these impacts aren't equal across all groups. We're seeing more deprived areas being worst hit. So it's absolutely something, it's an urgent challenge that we all need to address, really.
That's interesting when you talked there about the outcomes that it has. We saw some really serious outcomes this morning when we had two surgeons on a panel from Moorfields, and the outcomes they were seeing in some circumstances were people losing their sight because of waiting lists. And that kind of, I don't know, we get carried away with statistics, don't we? And that really kind of brought it home to me this morning. David, what about the impact on services? You're Managing Director of Vantage Health. I mean, you are at the sharp end too. What impact does it have on services, the size of these waiting lists?
So yeah, I completely agree with Ellen. And I mean, it's not exactly like we weren't warned or knew this was going to happen. I think 3 years ago, the NHS long-term plan presented a pretty bleak picture of where things were headed and stressed the need to eliminate tens of millions of hospital visits each year. Actually, within this document, they recognised that only through comprehensive service redesign could they avoid all these issues, and not least £1 billion of unnecessary cost. And at the time, there was a directive put out trying to reduce outpatient activity by 30%, and this cumulative effect of that's over the number of years, and obviously it made more acute through the pandemic, has just made it, reached boiling point now, and the pressures on the hospitals are just absolutely immense. So we have to find to deal with it, not just short-term fixes, but long-term systemic changes to actually ensure that patients are treated in a timely manner. And obviously with the clients that we deal with, they're desperate for ways to address this, and have come up with some very innovative methods.
hold that thought, because we'll come back to innovative methods even and solutions. I'm just delighted to see that we've managed to get you on, Jonathon, and our two other panelists have done a grand job of really answering your first question. So I'll get your thoughts and I'll repeat it just for you. You kindly provided the report for me that I just quoted that said 5.6 million people are waiting for treatment, and that's the highest since records began. So what I was going to ask for you, but Ellen and David have talked about a bit, and it'd be nice to add your thoughts, is the impact of big waiting lists on people and services.
Mm-hmm. Yeah, thank you very much, and I apologise for my technical lack of prowess.
It's not your fault, believe me. It's not. It's not always easy.
So, yes, thank you for referencing the report that I sent over. But in the time since that was written, the situation has deteriorated somewhat, and we're now in a situation where each month when new stats come out, we're in a position of saying it's the worst ever again, and next month it will be the worst ever again. And the Secretary of State, Sajid Javid, the other week explained that he expects that to be the situation up until at least April 2024 is when he expects the situation with the elective backlog to start getting better. So you ask what the impact of that is on the workforce and on patients. I think there are some commonalities across there. So people who go into work in health and care roles tend to do so because they want to provide a very good service. They want to look after, care for, and improve the lives of people that they work with. We're in a situation now where the health and care system is in crisis and just sort of having to keep on kind of head down, ploughing through. And so you're seeing a lot of stress and difficulty piling up on the workforce, who are having to do an awful lot with less, and that is having an emotional and physical toll on the health and care workforce, meaning that we went into this pandemic already with chronic shortages. The situation we're in now is probably only going to make that worse as more and more start to think, well, do I want to keep on doing this? Should I leave? Should I step away? And then when we look at the impact this is having on patients, then you get into some really quite heart-wrenching and concerning trends that are happening. So you get the fact that people who haven't shown up are living with undiagnosed conditions. So cancers, heart conditions, respiratory issues that have gone missing. That means that those people aren't receiving the care they need, and their quality and length of life is going to be affected by it. And then you have the stuff that I think we can sort of really relate to, is that if you're waiting for care, it's at best, it is frustrating, it's really annoying, and you're often living in pain, and that's going to impact your social life, your work life, all aspects of life, and potentially undermine quality of it. So I think there's an awful lot of quite, I mean intensely worrying, disturbing things happening. And I think we're probably in a situation now where more and more of this is going to start coming to the fore, and we're going to see more and more of these sort of issues of the health service being under pressure, refocused, and not working at usual capacity for two years. Are going to start coming through. We're going to start seeing more and more of it. I'm afraid. So I'm sorry, that is quite a bleak.
That's all very bleak, Jonathan. So we're going to look to Ellen and David. No, I'm just teasing. I mean, you've set the stall out very well, and as I said this morning, I've had first-hand experience with the NHS and my mum recently, and seen at first-hand, waiting twice for an ambulance for 4.5 hours, and the 999 teams apologising because there's just so many people and so few staff, etc. So I've seen it at first-hand, but there are positives we can look at, Ellen, aren't there? I mean, we can look at how we can use analytical tools, for example, to address some of the backlog and to help.
Exactly. So it certainly isn't all bleak. There are opportunities for us to use data and data-driven tools to help us address this. So in terms of specifically addressing the backlog, we can do things like have virtual appointments for outpatient care. We can improve patient flow for in-hospital care. We can deliver virtual care at home as well. These are all fantastic opportunities. And I guess to give you a couple of examples, cystic fibrosis care in Royal Papworth has been absolutely transformed by home monitoring. So we funded a project over there, which has given the patients who are accessing care for cystic fibrosis in the specialist centre, given them wearables, and they can record kind of key indicators like sleep, blood oxygen levels, sleep, lung function, which uploads data into the cloud so the clinicians can see that and make decisions. And in terms of how that helps address the backlog, it means that those sort of routine appointments that get scheduled, every however many months or however many weeks, they can be arranged according to need, which means that the unnecessary ones can get cancelled. And this isn't just, helpful for the clinicians and for efficiency. It's also helpful to patients for whom, having an appointment means taking time off work, or for those that rely on costly or unreliable public transport to get to hospital, because not everyone, lives very nearby. And within the project itself, it's estimating that about 50% of those routine appointments can be cancelled. And the tool also improves patient outcomes because fewer days are spent in hospital for, receiving things like intravenous antibiotics. The AI model that's running alongside this project can spot a decline in the patient's condition almost 2 weeks before antibiotics would have been started. So all of these things mean that the patient feels better, the clinician feels more informed, and the efficiency and capacity of outpatient services work better too. And another example of how we can use data and data-driven tools, I'm funding another project down in Bristol that is looking to bring routine data from a number of different systems which operate completely independently into an ICU reporting app. So all of the data from all of these different sort of non-interoperable systems. And what it means is that the staff have the information that they need to make key decisions about care, which improves patient flow and patient safety. And it sort of helps to save staff time, and it helps reduce things like, readmission rates and delayed discharge. So the initial focus is on supporting this ICU, reduce admissions for kind of elective care patients, but ultimately it will be used as well to kind of expand to support emergency admissions in their totality. So it just means that, through data on kind of staffing and theatre scheduling, we can really begin to match ICU capacity with demand and improve patient flow, which are all really important to clear the backlog.
They certainly are, and I think those examples really do help, Ellen, to sort of bring how digital can help to life. I mean, certainly, David, we've been forced, haven't we, probably through the pandemic, to think certainly out of the box digitally, and that's perhaps a good thing in many ways. You work with different trusts in the Northwest London integrated care system. You kind of teased us with some solutions. So what have you come up with that's really helped people continue to receive care during the pandemic?
So firstly, I share Ellen's optimism around the amazing things that can happen, and also would like to congratulate her for the amazing work that they've been doing as a family who's been deeply impacted by cystic fibrosis. It really does mean a lot that they're doing this incredible work. In terms of the work that we're doing, we're buzzing really, because it's kind of brought out this innovation from within the NHS, from clinicians who previously were very much used to the kind of bread and butter of just treating patients they normally would every single day, or having to do a lot of administrative work they didn't really want to do, to actually redesigning pathways or operationalizing pathways using systems such as ours, as Rego, that at point of referral can guide referring clinicians to ensure that patients are treated at the right place at the right time. The algorithms that we design educate them at that point of referral, and through our integration with various different systems such as the National ERS, make the process really slick and easy. So as an example, we've been working with ENT consultants across London, London Northwest and Imperial and Chelsea and Westminster, to be able to design a flow in which even advice and guidance can be avoided by upfronting a lot of that guidance through the program. And only when a referral is actually needed is that generated, and then we can actually direct it to the specific clinic. And again, dovetailing to what Ellen was saying, utilize things such as virtual clinics to say, actually, it doesn't need a face-to-face. This can actually be done as a virtual appointment, and identifying those cohorts of patients to be able to work with. We've also been doing some fantastic work with Imperial and Chelsea and Westminster around a single point of access for all referrals that come through, whether tertiary referrals, whether referrals coming directly via ERS or through our system. And being able to capture that data is really, really important. So knowledge is power, as we know, and to be able to identify the bottlenecks in real time is really quite significant and is quite unprecedented across the NHS. And with that power, we can then redesign services and address them quickly.
That sounds like you've been doing some fantastic work, David. We'll come back to you in a minute. I mean, Jonathon, there are inequalities, aren't there, in the backlog? What are those inequalities, and what are the causes, do you think?
So yeah, you're quite right. There are significant, persistent, and systemic inequalities within the backlog, and that risk of sort of being the negative panelist, or getting myself a name for that, I think it does present an incredible amount of concern and difficulty. So our research, our analysis showed conclusively that people in the poorest parts of the country are more than twice as likely to have to wait over 1 year for elective care, and that waiting lists have grown at a far greater rate in those more deprived parts of the country. What are the reasons behind that? So my hypothesis would sort of look at two specific areas. So inequalities in health are not new. They predate COVID by many years. So we were going into this pandemic where there were greater baseline of health needs in poorer parts of the country. And also we know that COVID discriminates fairly relentlessly and effectively against people in more deprived socio-economic groups. So the NHS in those parts of the country has faced greater pressure during COVID because there's been a high rate of mortality, illness, and infection there. So the two issues are the baseline of ill health being higher and COVID causing greater disruption in those areas. But to sort of reflect, try and be a bit more optimistic about it, we have also identified some parts of the country that were outliers and bucked that trend really effectively. And the things that were going on there were in some ways crossed over with what Ellen and David have talked about, the role of digital, of information being shared effectively, of systems being used effectively. But I think the other sort of really key enabler in this is the pooling and sharing of resources across NHS organizations having to move away from a mindset of competitiveness in the NHS, in seeing the NHS as a marketplace, and actually working more effectively in a collaborative or a system way, and thinking across it, and using data as well to help identify those areas, those communities that we serve, where inequalities are going to be experienced more greatly. So looking beyond the very specific condition level and looking more at the social and economic indicators of being at greater risk as well. So I think there are a lot of options and a lot of routes to addressing this, but you're quite right. As it stands, the inequalities here are stark and massive.
I want to move on to Ellen in a minute with data infrastructure, etc. But I just wonder, there's a little pick up there, David, for you. I'm just wondering whether what Jonathon said at the end resonated with you, and whether there have been advantages with working with multiple NHS providers in the same ICS in terms of collaboration and pooling knowledge.
I'll be honest with you, I didn't think there would be, but there has been. It's been quite amazing. If you take, and I don't think they mind me saying, but if you take two of the trusts, Imperial and Chelsea and Westminster, though they occupy the same space in the ICS, they're not really used to working with each other particularly well. And the way they've come together to collaborate on a joint project around Rego, joining in with London North West Hospital Trust and in Hillingdon, has been nothing short than remarkable. I mean, it's true collaboration across every single level, whether it's clinician, IT, operational, managerial. It's been astonishing having these joint groups every week, you know, sometimes 3 or 4 times a week, just to get a project stood up of this scale is really remarkable, and testament to the fact that they share a joint vision, and you know, and they're not being precious or egotistical. They're saying, right, let's work together, let's solve this problem, let's reduce health inequalities, and I think that's been incredibly impressive, and full credit to them for doing that. And we've just been a lucky recipient of that kind of that level of collaboration, and I hope that's reciprocated across the NHS, because that is the way forward. They have to think as a team, because you know, you close your doors, you know, if one department closed their doors to not having treatment done there, it would just create a problem elsewhere, and vice versa. They have to think as a group.
That's really nice to hear. Ellen, I want to talk to you about what we can do to improve data infrastructure, and also how we can make sure we can the workforce so that they're prepared to take on the kind of challenges that they now will have to face.
Of course. As I described earlier in those 2 examples, you know, having that really high quality, timely data really lays the foundation for important work to inform prioritization and improve patient flow, improve outcomes. So it's really important for us to do a couple of things. And actually, as Jonathon was saying, with health inequalities, it's incredibly important that we make sure we understand how our efforts to address the backlog are affecting different groups. And I'll come onto that in a sec. But so we really need to do 2 things to improve data infrastructure, I think. One of them is improving data quality, including addressing sources of bias that might impact health inequalities. But this requires buy-in from everyone, and to kind of come to that question on the workforce as well. In my experience, as when I was a jobbing analyst, data collection is kind of historically a local exercise where clinicians are collecting data to, you know, shape and inform the way that they deliver care. But over the past few years, what we've seen is, you know, data being increasingly linked and aggregated at broader levels for different purposes. And so what we need to be doing is reducing the burden of data collection on clinicians and other professionals like admin staff, whilst also kind of demonstrating the value of high quality data to them, because they're not going to be motivated necessarily to want to collect more data and more, a more granular level and much higher quality, unless they're really bought into it. So whether that's about telling stories of best practice or providing some reciprocal benefit, like, you know, helping them use that data to better understand their patients, and, you know, having this feedback loop to improve quality. It's just really important, I think, that we understand that behavioral and organizational change is, necessary. It's vital for us to be able to realize the benefits of data analytics. So that's kind of the data quality issue. Then I would also say we really need to be facilitating linkage, because at the local level, that helps clinicians make better decisions about the patients and the care with all of the information that they need. But at a regional and a national level, it helps us understand how services are being utilized and by whom, which can inform decision making and policy, but it also helps us spot where those health inequalities and inequities of access to services are manifesting. The data linkage means, addressing things like legal, ethical, and regulatory challenges, which can be resource intensive, but are incredibly important to protect privacy. We could make it easier for local teams to navigate those processes, I think, and that would help us make faster progress. But we can also learn a lot from these national efforts to link data. So we all know about the general practice data for planning and research collection, so the GPDPR, or as it became known, the data grab. That was paused because patients and the public didn't feel adequately engaged or involved with the process. They weren't confident that their concerns were being heard. And DHSC then paused it and announced that they would be using a trusted research environment through which the data would be held and analysed. And I think this is a cautionary tale about we really need to engage patients and the public in data analytics work as a whole, not just through data linkage. So those are the two priorities, but they do really kind of link in with how we want to be improving the workforce, or making sure that we're equipping the workforce with the right kinds of tools for them to be able to take on this challenge, because it's not necessarily going to be easy. And once we kind of have sorted out the data quality aspect, we need to think about what software tools that the analytical workforce needs. There's a community called the NHSR community, which is an amazing community full of really enthusiastic analysts and managers wanting to kind of better collaborate using open source tools. Now, there was a survey that they did. Most of the community members that are part of the community use Excel as their main tool, and then R after that. If we were able to equip the workforce with the right tools to be able to automate some of the really high effort, low value jobs that we kind of call this analytical churn, we would be able to free up analyst capacity to undertake more sophisticated work that could generate insight, support decision making, and really kind of support the addressing of the elective care backlog. But as long as people are still using Excel, it feels a bit out of our reach. So certainly some investment there, but happily the data strategy that was announced, written, and released fairly recently, DHSC has really committed to kind of working more in an open way, encouraging this kind of culture of open analytics, collaboration, learning from one another. So I think that we're getting there.
Ellen, we're almost out of time, and I'd like to give David and Jonathon a final thought, but just a quick one from Richard to you. So if you could be really brief, if you don't mind. Actually, the question's just disappeared. Bear with me 1 second. Richard says, do you think that the data quality has suffered during COVID-19 due to the impact on the workforce? Just a brief one to that, if you don't mind, Ellen, only because we're kind of running out of time.
Of course. So I think in certain respects it has improved, but certainly in some places, I think where people have been asked to collect far more data and report far more data, things have been compromised in some areas. I've realised that's a bit of a cop-out question, but it could always be better, I suppose.
Jonathon, your final thought, really. Do you think we need to reprioritise patients regularly? I mean, we've got people, haven't we, been waiting 2-3 years. Some will have got worse, some will have stabilised, some sadly may have passed away waiting. It's do we need to look at the people on our waiting list and reprioritise?
So the short answer, I think, is we're in a situation where, yes, we will have to do that. That will have to utilise a lot of the kind of population health management tools that Ellen has talked about, identifying where need is and what kind of profile of need we have and who's been waiting a very long time, and try to address the waiting list in an equitable way. My concern, however, is that the pressure to work through the backlog from the centre will focus very much on the top line figure. We need to drive this down to an acceptable level, no matter what. So you're concerned about the average only, not the extremes and the iniquity in it. So that's my concern.
Thank you. And David, just 1 minute left, really, just to ask what you're hoping to achieve over the...
So what we would love to do is to expand our services across other ICSs in the same way that we've been doing, basically replicating the work we've been doing in Northwest London, because I think it would be hugely impactful. To be working with trusts is a really amazing cutting edge place to be now, because they are so keen to address the problems that there are. So I think that would be our main focus. Well, just keep on going and doing some really great things for the NHS, and we're really proud of that. So yeah, that's
Brilliant.
That's
David, Jonathan, Ellen, thank you so much. I hope you'll join us at some point on another of our NHS virtual events, because you've all been fantastic panelists. And as I seem to say at the end of every panel today, the time has just absolutely flown by. So thank you very much indeed for making time in your day to join us. Thank you. We're going to jump to another break now. This is your last chance to get the most out of the event by utilising all the functionalities on the NHE365 platform, whether you want to make a connection, share thoughts in the live chat, or submit a question in the live Q&A. So we'll see you back at 2:55.